Our presenter today, Matt Gibson, is particularly passionate about improvement in vascular access and infusion practices to eliminate associated complications. He strives to accomplish this by serving on national and regional vascular access and infection control committees, writing evidence-based education programs, and speaking publicly on a range of vascular access and practices. He's worked clinically, as you can see he is doing today, placing vascular access devices in an extensive number of facilities across the country in every patient setting, including acute care hospitals, LTACs, outpatient infusion clinics, and home care. He's trained hundreds of clinicians over the last 2 decades on insertion care and management of vascular access devices. And given his certifications in both infusion and vascular access, he provides unique clinical insight into the bedside aspects of vascular devices, and we're so grateful to have him here with us today. So please join me in welcoming Matt to our concluding Wednesday workshop in this series. Welcome, Matt.
Hello, everybody. I'm so glad everybody's here. This has been such a fun project, honestly. And the third and final session here is mastering maintenance. I wish in 20 minutes I could tell everybody how to master maintenance for every device in every aspect. But I did have to create a little more narrow. And what I'm really focusing on is dressings and how I'm going to poke a couple holes in stuff as far as what we're currently doing. And I really want you, the goal of this is to really hope that you can consider what you're doing, take a look at it, dissect it, and really see what you can do with your dressings. In the last session, we talked about, do we have a problem? And we know that dressing disruption is an independent risk factor for catheter-related bloodstream infections. This is from Tenzin 2012, and we know from Richardson's article and research that the dressings really aren't staying on as long as what we think they are. It's been about 2 weeks since we really hit this hard, and I wonder if anybody that's on there now, has anybody started measuring their dressing disruption? Just a candid question, because I had that call of action. A quick reminder about the dressing stains change practice, standard of care. Change immediately when it's disrupted, and they've done a really nice job of describing dressing disruption: lifted, detached, any bordered edge or any area of the transport area of the dressing in the presence of moisture, drainage, or blood. And you can see, if you walk through your halls of pretty much any hospital, you will find similar situations in devices just like this. But what we're trying to get to is something like this. This is what the real goal is. So with any with any quality improvement, you need a process. And all you got to do is Google quality improvement process, and all kinds of different frameworks come up. This is the Plan, Do, Study, Act model. You've obviously, with the nurses out there, we have the nursing process. It's the same. That is quality improvement, honestly. So pick some framework that you can design the quality improvement around. And you're going to have baseline data. Regardless of what you're doing, what you're collecting. In this case, we're talking about vascular access complications. Central lines primarily. We can collect the data. You decide what your data points are. If you don't know about Excel or how to use Excel, there's people out there that does. And you can collect this in a central location, like a shared drive or a Google Drive or some type of other drive. And if you know somebody that's really good with this, and ask your teenage son, probably will know how to use this a great deal, and they can create formulas where they self-calculate, so you keep a running tab of everything, and it makes it nice and neat. But this is important for the quality improvement. So ask for help. And not only in your friends and in your facility, but your vendor partners. Tons of the vendor partners that we have some programs that can help focus your baseline data. And Eliquis, this is an example of what they would do for dressings. You can see it's very neat. It's concise. When you get it drilled down into this, it has a legend where you know, it talks about all the different catheters, all the different locations. What I like about this particular data collection tool for dressings is that it really breaks this down. And look at the way this is formulated: intact, edges lifting, reinforced, detached. You know, these are similar terminology that we have coming straight out of the standards of practice. So now let's get into the actual, you know, care and maintenance of changing the dressings. So here's a polling question. This is so interesting. I'm so interested to see what people say here. This is look at this polling question. During a dressing change, I changed my gloves and donned sterile ones immediately after removing the old dressing and adhesive securement device and prior to cleansing the skin. That's option 1. Or I immediately removed or I changed my gloves and donned sterile ones immediately after I removed the old dressing, securement, adhesive securement device, and cleanse the skin. So the separation here is what I'm trying to get to and ask people what their practice is. Do you cleanse the skin before or after you change your gloves? So some people remove the dressing and then they're going to don sterile gloves and then they're going to go back and clean the site. I find this very interesting, you know, because whenever we consider aseptic non-touch technique, which that is for an invasive procedure, but if we apply those same principles to dressing changes, I think we can find some gaps. So that's what I'm trying to get to here, and I just want to see what everybody's doing. So 25% of the people change their gloves after they disinfect the site. Okay, that is curious. So 75% are going to remove everything, put sterile gloves on, and then go back to clean the site. All right, we got it squared. So whenever you're looking at competency and this particular skill, if you're not aware, if you haven't seen this, the infusion therapy, the infusion therapy clinical competency validation program exists. It is a huge document, honestly. It's produced by the Infusion Nurses Society, and it talks about this particular skill. This is central vascular access device, site care, and dressing change. If you have, this is standardized. This is, you know, easy access for you guys. If you don't have something, this is a great document. But as you're looking at this in the standard of care or this clinical competency, this I think can be problematic with adhesive securement devices. What we have here is we don clean gloves, we're going to remove the existing dressing, and then we tape the catheter to the skin. This is part of the competency. Then we're going to remove the engineering stabilization device, and then again remove your gloves. So this, nothing about cleansing the site. So those of you that are, 75% of you that are removing the dressing and then donning sterile gloves to go back and clean the dressing, this is actually what this says. I find a little issue when you have to tape this down, and what I'm going to propose today is maybe a different approach to this. So once you tape the catheter down and you're removing the adhesive engineering stabilization device, I find this extremely difficult. When you tape the catheter down and then you try to remove this device, it doesn't work without pistoning the catheter in and out at the insertion site. And here's the example. I'm going to show you what I'm talking about. I've taken the dressing off. I have a securement device on there, adhesive securement device. I'm going to tape this down so it doesn't move, and then I'm going to go back and I'm going to try to take this off. Now, how do you take this off if these pigtails are taped down without pistoning that catheter in and out? You can't, because it's secured on both sides and you can't peel this thing off. So I think that this particular procedure is problematic. So once you don sterile gloves, then you go back and clean the site. But honestly, I find this very difficult to not contaminate your gloves. And here is what most people are doing. So if you do in fact follow this competency and you tape it down, then what you're going to, and this honestly, you have to take the securement device off first, then tape it down. When you go, then I'm going to change my gloves. Now I'm coming back with sterile gloves, and this is what most people do. You grab it with some gauze and you hold it up. What I'm proposing to you is it's very difficult to prevent the migration or pistoning of that catheter when you do this. I have a little bit different approach. And here's my approach is we use ANTT and we identify the key site and key parts so that once we clean this, we can actually touch this. So as we're cleaning all of these sites, disinfecting them, then you can touch them as you're putting stuff back. Now, another way here is a subcutaneous securement device. This is why I absolutely love this device, because you can literally lift this thing up, scrub the skin all around it, and you never have any migration or pistoning of that catheter. So here, this is a vigorous scrub. We're getting in all the nooks and crannies, but this catheter is not pistoning in and out. The skin is staying stabilized. You see the skin moving, you see the catheter moving, but catheter is not moving in and out of the skin. This is superior securement, if you ask me, and this is how we master the maintenance of this, by providing the stability. Now, again, you go back with the sterile gloves. If you use this kind of disc, you have to have sterile gloves. If you have a CHG gel dressing, you're not actually touching that site after you go back. Or if you're using a securement dressing, you're also not touching the site. So those things, or if using a drop of glue, to seal stuff off, whatnot, you're not actually touching the site. So I challenge everyone. I challenge everyone to go back and look at not only look at their procedure, but look at their practice. I find a lot of contamination with these dressing changes. It's touch contamination, tons of pistoning of the catheter in and out. So I invite you to go and make this part of your quality improvement as to how this is being done. And you do not see this standardized throughout the whole hospital. If you watch 10 different people do a dressing change, it's really 10 different ways. So, mastering this maintenance is standardizing and making sure that everyone is doing it the same in proper way. So for one last thing, to keep the dressing on, this is an example of how the gum mastic product is used. I've got this catheter in, and I literally just trace this right around the border of where that dressing goes. It takes 7 seconds. And in my opinion, in 7 seconds, you're going to save the dressing for 7 days. And, part 2 in session 2, we talked about the work that Shelley DeVries has done and the amazing outcomes that she had with this particular product. So what I found through my observation is touch contamination with dressing changes is horrible. It's due from a poor aseptic technique. I think what we ought to be doing is integrating the principles of key parts and key site into our dressing change so that we can help identify the parts that we can touch and the parts that we shouldn't touch, and also in using improved securement to prevent the micropistoning, because this is prevalent. Micropistoning is a real thing. It happens a lot. And then whatever dressing you are using, you need to use it properly. Especially if you're using a double incised dressing where you have layers of different dressings. It's everybody needs to know how to use those products. And another observation I find is, Mike, people really do not like adhesive securement devices that they have to manage and leave the catheter exposed for pistoning and micro pistoning and migration. Things that can help we can identify what our rate of dressing disruption is, what our rates of migration and dislodgement is. Dislodgement is a little easier to track. Migration is really tough. It really takes some diligence to do the observations for this data point, but it really is worth it. You'll be surprised at what you find. Most people, when I say, hey, do you guys have a dislodgement problem? Oh, no, we don't now. And then, maybe once a month, and you have 10, 15 people on the team, and it's 10 or 12 dislodgements. And then it starts to, come into focus that, oh, this is maybe a problem, because you know what? It's preventable. That's the thing that is remarkable. So also identify the compliance to your aseptic technique. I'm telling you, it's, I've seen things that just make me shudder because of, I just feel like we're trying to kill patients. And some change that you can implement, obviously, for the dressing disruption, you can use the gum mastic for better prevention of micropistoning migration. The subcutaneous securement is fantastic. And then we really need to look at standardizing our process and our products. I've been in hospitals where they've had, they may have 5 different dressing change kits on different areas of the hospital, to do the same work. So this does take a little bit of work and effort. You can lean in on your vendor partners for this type of support and help, but it will certainly be worth it in the end. And that's all I have today, you guys.
Thank you so much, Matt. I appreciate your taking the time to walk through that content with us today. We got some comments about how wonderful your presentation was. Thought I should share that with you. But with that said, we are now to the Q&A portion. So for anybody who has questions for Matt, please feel free to enter those into the question box. We do have a couple that have already come in. Matt, are you ready for your first question?
Certainly.
All right. So with that said, isn't some level of dressing disruption inevitable?
This is a common question that I have during these types of presentations, and I answer this with perspective of the dressing. Yes, we can anticipate some level of dressing disruption. But what is that? For me, any type of dressing disruption marks the beginning of the failure of the dressing. That means that dressing will likely fail at some point in time, but we don't know when that's going to be. We don't have eyes on these dressings 24 hours a day, 7 days a week. Even the patient isn't aware of the dressing, 24 hours a day, 7 days a week. So in my opinion, and it's supported, actually, I support the standards of practice that say you immediately change the dressing with disruption, with the defined terms. So, and that's how I perceive this and understand this, is the dressing disruption marks the beginning of the failure of the dressing. So if we want to prevent, the complications that come with failed dressings, then we need to be attentive to that and really eliminate reset that dressing so that it doesn't begin to fail.
Great, thank you. So another couple questions. So are you able to share what the stabilization device was that was used in the video? The orange one, I couldn't see the name well.
Oh, yeah, and this actually is not a CEU program, you guys. I just use the generic terminology just by habit, honestly. But that is called the SecureCath. It's a subcutaneous securement device. If you Google it, there's tons of information. There's tons of videos on the website that you can go to and look to see how it functions, the insertion of it. You saw, the glimpse of the dressing change as far as the disinfection of the site. There's also in the previous sessions, there are insertion and removal videos that you could also dial into and see. So if you have more questions, there's definitely answers out there. All you got to do is visit that website. It's a very robust platform for education.
I agree, absolutely. Lots of videos and print resources as well. Okay, so next question. What do you think has happened in the past 20 years that's made vascular access science even more important now? Is it lack of training at the bedside, or is it, in a way, due to regulatory reporting of CLABSIs?
Well, maybe we've just realized that we actually are killing people. Because bloodstream infections, they kill people. It used to be in the 2000s, especially before the Keystone Project, whenever Provenos did the study that showed the insertion bundle that has, helped so much. Really, it has raised the awareness of what we are doing, and it's still, I tell you, I feel like with this global pandemic stuff, we've taken 4 steps back, and we see that in the elevation of bloodstream infections. But you know what? It's funny, whenever you break this down, it's primarily in that population. So pre-COVID, I think the reason why is, one, the financial penalties from central, CLABSIs have definitely raised the awareness. And it was a reactive type of measure. We're getting financially penalized, and so now we have to do something about it. There is still, the peripheral IVs is just absolutely is being overlooked. More and more attention is being brought to peripheral IVs and the consequences, the complications. Listen, PIV can kill you just like a central line can, and so. The current struggle is in the environment, and I've seen this all over the country, is short staffing, high acuity of patients, high demand for healthcare, and just not enough to go around. Hospitals, every single hospital I've walked into in the last 6 months have had a critical staffing shortage, every single one of them. So all of that plays into where we are now. And I feel like every time we take 2 steps forward, we take 3 steps back, so I don't really know if I answered any of that question or not, but I'm just rambling on. Sorry, guys.
Thank you. Thank you for your perspective. Well, with that said, we're at our time. So thank you so much, Matt, and to our audience, on behalf of all of us at EloQuest Healthcare, I'd like to thank you for attending this Wednesday workshop.